You came along and everything started to hum.
Good afternoon and welcome. I know a lot of folks in the audience today are new to Wisconsin Parkinson Association and our program. So if you don't know me, I'm Gary Garland, Executive Director here at WPA. And I have the pleasure of welcoming you to day one of what will be a week-long recently diagnosed series. We've lined up some of the smartest minds on Parkinson's in our state, and you're going to find something new each day. So hopefully you'll join us every day of the week. I suspect, like myself, you've grown tired of gathering like this virtually, but I'm glad we have that option. And I think in a couple months, we're going to find ways to meet again safely, and that's going to be a very good day for all of us. Because so many of you are new to our programs, I want to give you a brief overview of what Wisconsin Parkinson Association does. In a nutshell, we're focused on helping you live life as healthy and as fully as possible today. We do that really in three program areas. The first is education. We host many programs just like today's throughout the year, all around the state when we're not under COVID restrictions. We have a great website. We have a fantastic magazine and e-newsletter. And if you want to talk to a real person, we have staff dedicated to answering your phone calls and your emails. Because everyone's Parkinson's journey is different. And so really one of the greatest resources for you is to have the most accurate and recent data available. And we make that easy for you. The second program is exercise. And I hope everybody out there is exercising. WPA hosts 8 exercise programs, Parkinson specific exercise programs around the state. And we do that because if you have Parkinson's and you're exercising regularly, you are likely to realize both physical and mental health benefits. And the final program is one I'd call community building programs. And really, this is just an excuse for us to get together and have fun. For example, in the past few months, we've hosted 4 virtual game nights. And before COVID hit, we had in-person opportunities, including working professionals with Parkinson's socials and even fly fishing days. The real danger, one of the real dangers with Parkinson's, as with any chronic disease, is isolation. We want to help you fight against that and at the same time have some fun. So I hope you've already gone to our website. There's more resources there than I can list. So check it out. But one of the resources you want to look for is our videos. And those are produced with the help of local Parkinson's health experts on a variety of topics. That website is wiparkinson.org. So as we get started, I'd like to first thank our sponsors that make this week possible. Those sponsors are Medtronic, Amneal, Boston Scientific, and Kieran. Just a note, as we get started, you are muted. We cannot hear you or see you, but if you have questions for our speaker, you can use the Q&A function. That's at the bottom of your screen. Just type in your question and submit it. We'll get to as many of those questions as possible at the end of today's presentation. If we don't get to all the questions submitted, we'll try to address those in either future programs or in our future publications. So let me introduce today's speaker. Dr. Lisa Kokontis is a neurologist at Neuroscience Group in Neenah. She grew up in Eastern Iowa, went to Iowa State for her undergraduate degree in microbiology. She headed to Eastern Iowa for medical school at the University of Iowa. She kept heading further east to complete her residency in both internal medicine and neurology, and then a fellowship in neurophysiology at West Virginia University. Finally, she came back to the Midwest in 1998 and has been with the Neuroscience Group ever since. Dr. Kokontis and her husband have 3 daughters who she says, quote, "We hope to bother a lot when I retire at the end of May." We're proud to say that she's a member of WPA's Medical Advisory Committee. Dr. Kokontis is going to cover how Parkinson's is diagnosed, what your neurologist is looking for, and the main motor symptoms of Parkinson's disease. Welcome, Dr. Kokontis.
Hello, thank you. Thanks, Gary. I'm happy to be here today. All that education, yes, definitely puts me in the egghead category. So I'm proud to say I'm an egghead. Welcome to right here. I am, here we go. We're just getting started. I wanted to share my slides. So I was asked to cover just the beginning of your journey. So the first thing that people think about is how do you, for Pete's sake, how do the doctors know that I have Parkinson's disease? What are the clues? What are the symptoms people have? What kind of characteristics do they look like? And so today we're just going to go through some of that for you.
Later. Full screen. Oh,
Got
right
it. Okay. And there we go. So, we've known a lot about Parkinson's. We've come to know a lot about the diagnosis of Parkinson's way back. In 1817, it was first characterized and described by James Parkinson. And he wrote this essay on the shaking palsy. And in that, he talked about a series of patients that he had seen that all looked similar to him. That was well before we had any medications to treat, but certainly it helped describe the clinical syndrome of Parkinson's disease that we know today. Actually, Parkinson's disease was described for thousands of years even prior to that, but it was Dr. Parkinson who thought to write down his observations into this essay. So sometimes we have students here. We love to have students here. And when I was going through medical school and then residency, we talk about diagnostic hallmarks of certain things. And sure enough, for Parkinson's, we talk about four different diagnostic hallmarks. What that means is when someone comes into your office, what are they likely to complain about or talk about or notice? And then your examination, what are you going to be looking for too? And the first thing people may notice is slowing down. The name for that, the medical name for that of the term is called Brady is slow, and then kinesia is movement, so slow movement. We'll talk a little bit more about that a little bit later on how you might manifest that slowness. The second thing is muscles. The muscles are tight and rigid. There's poor relaxation. It's not something that people typically talk about when they come in. They don't say, I have muscle rigidity, or my muscles feel like I have cogwheel rigidity, but they will notice things differently, that something isn't quite right with their muscles. The third thing is resting tremor. And sometimes the tremor is really all that people notice when they manifest symptoms of Parkinson's. A tremor that kind of can begin almost unnoticed and then a little bit more, and it's usually intermittent. And then it becomes more frequent, and then other people notice it. And that's usually when we get to see you, is someone else has pointed it out. Lastly, this doesn't happen till later in the course of Parkinson's, but there's a loss of balance. So sometimes people come in with loss of balance, and that's one of their first symptoms of their disease. If that's what would be your first symptom of disease, and I wouldn't think Parkinson's, I may think something else, some other Parkinsonian syndrome, but not the run-of-the-mill idiopathic Parkinson's. Usually the loss of balance occurs many, many years after the onset of symptoms. So, there's other features. Someone might tell you that you have a softer voice, or I can't hear you. Can you speak up? Your speech might be a little slurred. It's oftentimes your spouse that might notice this, and you may become irritable because you think you're speaking loud enough. It's their fault. It's not your fault. Their hearing is bad. It's not mine. I'm not speaking too softly. The other thing that your spouse might notice is a masked face. We call it a masked face, not that you're wearing a costume or a mask, but it's expressionless, or a poker face. You hide your emotions, and that's again a manifestation of slow movement. The muscles in the face aren't moving like you ordinarily would to show your emotion. A lot of people will tell me my handwriting has gotten so bizarre. It's very small. I used to have beautiful handwriting. People would compliment me, and now it's small. It's hard to write. It's hard to read. The other thing that people will notice is their walking has changed. They now don't feel like they can stride out. Their legs are tight, and then they'll look like they're shuffling their feet. Your spouse might say, pick up your feet, and then after a while they get more angry about it. Well, that's part of the features of Parkinson's. Some people have, when I first see them, the muscle tone. Remember, we talked about rigidity or poor relaxation, and that's what we're talking about. The muscle tone is increased. And sometimes they will complain, or you will notice that it is abnormal because you'll assume a certain posture. The foot of the person might turn over. It's not controllable. Or the hand or the wrist might become more tight, and it's hard to open up the fingers, open up the hand, and it's hard to turn the hand and wrist. That's called dystonia, or abnormal tone. That's not a common feature of Parkinson's disease, but occasionally we will see that. So I mentioned it here. Some other features are feeling lightheaded when you go from sit to stand, or from laying to sit to stand, or even passing out. And these are symptoms of the Parkinson's too. You wouldn't think of it. It's not related to movement, but that's another realm of how Parkinson's can affect your body. Other autonomic, or the automatic system, can also become affected, and constipation can occur even years and years before the actual motor symptoms, the 4 other symptoms we talked about, occur. Urinary incontinence and sexual dysfunction, inability to have an erection if you're a man, or reach orgasm. Those are things that can occur even years before the other symptoms of Parkinson's can occur. Some other features, these aren't commonly seen upon diagnosis, but some other things to kind of notice or understand that this could be your Parkinson's. Some difficulty with swallowing. So your muscles that affect your movement, we always consider our hands, our arms, our legs, but we also will have other muscles that are more automatic. The difficulty with swallowing is due to the swallowing muscles of the back of the throat. Again, it's slow. Dry skin happens. There's a certain kind of a distribution of the skin change. It's usually on the creases of the nose, or in the folds between the nose and the face. It becomes drier, crustier, and a little oilier. That can be a sign of Parkinson's. Now, that's also a certain skin condition. So if all that's what you have, don't worry, you don't have Parkinson's, but it is associated with Parkinson's. Some people have this sleep disturbance. The RBSD, that stands for REM behavior sleep disorder. And that is another symptom that can occur many, many years prior to the other features of Parkinson's, like tremor and slowness. And how you present with this is typically your bed partner tells you that you had dreams that you kicked and punched and hit, and maybe even choked your bed partner. And in other words, you're acting out your dreams. And normally when we sleep, our brain paralyzes our muscles during our dreams so that we don't act out our dreams, so we don't hurt ourselves or anyone else. But in Parkinson's or Parkinson's disorders, that sleep paralysis doesn't occur, so you can act out your dreams. And again, that's a symptom that can occur many, many years down the road, or I'm sorry, many years prior to the other symptoms. Some people who have Parkinson's feel sensory changes. That's typically, let me get ahead here. The sensory changes can be coming and going. It can be something you notice when you start to have medications to treat your symptoms. And it can be a wearing off, a feeling of a wearing off of the drug. So it's time to dose again. Some people will feel that they have numbness and it's time to dose again. Or one man I've seen, he came to me thinking he has a problem with his peripheral nerves or a peripheral neuropathy, when really he had clear findings of Parkinson's disease, and he was having a sensory phenomenon related to the being off, not having enough dopamine in his system. Now, other features are depression, and usually, obviously, we don't present with depression and then get diagnosed with Parkinson's disease. But I just mentioned depression and dementia and fatigue as common associated features. So when I see someone with Parkinson's disease, I don't just try to treat your tremor or your movement, but I'm happy to help you with depression or sleep disturbance, or are we starting to have cognitive issues? We want to make sure we key in on the things that you need us to treat you for. So, those are the things that I run through with medical students. Hey, look for this and that. But what you'll hear, and I always do say as we come out of the room after seeing a person, listen to their story. They're not saying, I have, again, cogwheel rigidity, my muscles are stiff, I have shuffly gait. They're saying these common complaints. I'm slowing down. I used to think it was because I'm getting older, but my wife thinks I'm a lot slower than I should be. Or a lot of people say to me, you know what, when I first wake up in the morning, I just can't get going. I try to get out of bed and I fall back down, or I can't even move my body across the bed to get my legs to the side. I just cannot seem to get moving. Or my legs are in quicksand. They feel like I'm in quicksand. They're heavy. I feel like I can't move them the way I need to. These are some common descriptions of, just the slowing process. I can't get moving. Those are very common complaints when the legs are involved. When the upper extremity is involved, it's different. I'm shaky. My hand doesn't want to work. I'm right-handed and I can't seem to figure out, I can't comb my hair. I can't brush my teeth. My hand doesn't do the fine movements that I used to have no problem doing. My handwriting has gotten smaller. My hand shakes when I'm reading the newspaper or watching TV. Or a common one I see a lot is my dad had Parkinson's disease. I remember he had a tremor, and now I have a tremor. Do I have Parkinson's disease? That's a common one. So I hope usually when I see people the first time, based on some of these findings that we're going to talk about, that I can tell you whether or not you have Parkinson's or is your tremor related to something else. Some other common complaints are signs of slowing in your thinking. I'm in a fog. I feel like I'm in a brain fog. I can't seem to get my words out. I know what I want to say, but I can't get them out, or they stutter. They just can't get the words out because there's a stutter component to their speech. It's different than it used to be. And here's what your spouse or your family or your friends will notice. This is common. He can't keep up with me when I'm taking a walk. I used to be the one that has to trail after him, but now he trails after me. Or they seem to lose their balance so easily. There's nothing that pushes them over, but yet they want to fall backwards. Or she walks hunched over. Her posture is different. She's shuffly, slow. I can't hear her. She mumbles when talking. A lot of wives pay attention to their husbands when they're watching TV. I can't say that the reverse is true, but surely I hear this a lot from wives, that he's shaking when he watches TV. He doesn't notice it, but I look over and his hand is shaking when he's just watching television. Here's the REM behavior sleep disorder. He kicks or he punches out, he yells in his sleep. In fact, we don't sleep together anymore because I kept getting woken up or hit or kicked. So some variations, we always think about Parkinson's patients when they first present. They'll have a tremor, and a lot of people will say, I don't have Parkinson's disease because I don't have a tremor. Well, that's not true, because 30 to 40% of people who have Parkinson's disease will not have the tremor initially. It may come down the road in a few years, or they may not have a tremor at all. But just because you don't have a tremor doesn't mean you don't have Parkinson's disease. Remember, there are other diagnostic features and clinical hallmarks of the disease. The tremor, it can begin intermittently, and the person may not even notice. It usually involves one side or the other. It doesn't matter if it doesn't matter which side is your dominant side. It just chooses, the disease just chooses the side it may affect. It usually affects one side first and then the other side, usually many months or years later. And over time, it can increase in frequency. And so that what began as intermittent now is more frequent or is all the time. And it used to be a smaller, more subtle tremor, but now it's very large in amplitude, and it's hard to not notice it. The tremor, is different too. It can vary. It can involve the wrist, so that the hand is tremoring, or the fingers. It can even affect the leg, the lower extremity. I've seen people who only have leg tremor or foot tremor, but no upper extremity tremor. That's how they present. It can even involve the jaw. So maybe no limb tremor, but they have jaw tremor. And that's, again, if there are other features of the disease, such as slowness and tight muscles that can make the diagnosis of Parkinson's, even when there's no limb tremor, but just jaw tremor. The features of the tremor is classically a resting tremor. So when you're not using your arm or your leg, it happens. It starts to move. And it can get better when you're trying to use it, such as spreading peanut butter on toast or brushing your teeth. Maybe it's a little better, the tremor goes away. But if you do that activity long enough, the tremor usually comes back. For instance, if you're just putting the newspaper out and holding it, initially the tremor goes away when you're in that posture of holding the newspaper, but after maybe 10 to 15 seconds, the tremor will come back. So in some people who have a Parkinsonian tremor, a lot of times actually in the olden days, we used to say we can make the diagnosis of Parkinson's disease simply by a medication trial. In other words, you see if your symptoms of whatever you come in with get better with giving you dopamine or levodopa. But we quickly realized that there is a fair amount of people that have a Parkinsonian tremor, and it is truly due to Parkinson's disease, and it doesn't respond to medications. So the disease course, what's going to happen to me once I'm diagnosed? How fast do things progress? And the good news is things will progress slowly and insidiously. So it's not one day you'll wake up and have a tremor that's suddenly severe. It will gradually and slowly worsen. It's often the case where people really are unaware of the start of the symptoms. There are certain conditions that people will tell me exactly when it started. For instance, if they had a stroke, that day and time, the minute that stroke started. But in terms of Parkinson's disease, you may be unaware of it. It's so minimal, it's so slowly progressive that it may have started, months. I've had this for, quote, a long time. Well, maybe is, I don't know, a year, maybe two. It's hard to pin it down because it's so slow and insidious. A lot of times, people live with this for many, many months or even years. They really don't know that there's anything wrong until, again, someone can point it out. And they may say, yeah, I'm just slowing down. It's my age. It takes me hours to complete ordinary tasks. But, I think I'm just getting older. The slowness and the inability to move well will always respond to medications. And so that it's oftentimes the case when people's medication wears off that it's when they really understand how slow they are. In other words, when you first see them in the clinic, it's not clear to them how really slow they are until you treat them and their medicines then wear off and they're back to their baseline, that they really understand how slow they were. Again, it just speaks to how slowly this process can occur. So what happens as time goes on, the muscles are stiff. The shuffling can occur. The steps are small. The stiffness in the muscles are usually reflected in walking more so than the upper extremities. And if you watch someone walk and they have Parkinson's disease, same with tremor, how it starts on one side and then the other side. Similarly, with the stiffness in the tone in the muscles, it also starts on one side and then can affect the other side. So if you watch someone walking, you can see that there is increased tone in their leg. They may have to step over their foot because the ankle foot joint is slow and stiff, and you have to actually pick up the foot. The hamstring muscle, the back of the thigh muscle, is tight, and so shuffling occurs. They just simply can't pick up or stretch out the hamstring, so you can't really stride out. Your steps are a lot smaller. Stiffness is also seen in poor handwriting. When you think about writing in cursive, you have to have fairly smooth, small, dexterous movements, but that is very difficult if you have Parkinson's when the tone is to a significant degree in the hand and it's somewhat ratchety, and you can see a little bit of that in the handwriting. I had recently saw a fellow who, again, I hadn't seen him for about 6 to 8 months ago, he had a job where he had to write some things down, and then month after month he had some writing samples he actually just picked out of his work file, and he could tell when his Parkinson's disease started based on his handwriting sample. It was quite interesting. So what is the course? A lot of people want to know, even if you're new onset or newly diagnosed, what does the future look like for me? Well, it really depends on what age you're presenting and your symptoms. And I tell everyone, everyone's course is unique. Really, you can't read something online on a chat room or even on the computer and say that it's going to apply exactly to you, because everyone's course is unique. The length of the disease course, of course, depends upon the age of onset. So if you're young onset, we say that's when you're less than 50, your symptoms can evolve over many years and sometimes a decade or two. If we look at across the board, not necessarily in Wisconsin, but across the board, the average age of onset is 55. And also there's late onset of Parkinson's disease, which when symptoms begin over the age of 70, and your symptoms can then progress a little bit more quickly. Your doctor who sees you will, if you're seeing a particular specialist or like a neurologist, based on their experience, they likely have a very methodical approach to treatment options. You'll get into that more as the week goes on. What do I take why is my pal Freddie taking this? And I got started on that. It really is unique. The treatment is unique. The disease is unique. The medication management depends on your symptoms, as well as your age of onset, as well as all your other medical issues. I even consider, whether or not this is something that's affordable to people, because what's the point in prescribing something that you can't afford? It doesn't make sense. This is such a true thing too. I learned this like my first probably 2 or 3 years here, that there's such a wide variety of symptoms at onset. Because it can be anywhere in the course of the disease. Like I said, some people may not recognize a problem until they're really starting to lose balance, or it's taking up their whole day to get themselves dressed. Some people notice a little bit of movement in the thumb, and especially if your dominant hand is involved, you may pick up on the fact that it's harder to stir your coffee in the morning, or brush your teeth, comb your hair. Some of the more fine rhythmic movements that you have to do, like stirring, become more difficult. And if it's in your dominant hand, you might present earlier. You likely would present earlier. So those are the symptoms that we see as people come in. A lot of the times I didn't mention, what do the doctors pick up on when they see you? When I was a resident in neurology, in our clinic workroom, there was a framed picture that said, history is 90% of the diagnosis. And I think that's true in just about anything, not just neurology. So you really want to listen to how people describe things, because they're huge clues into what's happening. But when we do see people and we look at them, the things that we all want to take note of are how well you do rapid movements with your hands and your feet, and how loose are your muscles. And every doctor has various ways of looking at those things. And the good thing is with Parkinson's, it's pretty clear because as I said above, before, it's really unilateral and you always have a normal side to compare to typically. And so you can see how tight someone is on one side and have their other unaffected side as sort of the normal or the control to compare it to. This last thing is the Movement Disorder Society Unified Parkinson's Disease Rating Scale. There are some centers that look at this every time you're seen. It's quite involved. It's really a nice, useful tool for us to be employed in studies. And I just wanted to touch on this. What is this? So this is the UPDRS was originally developed in the 1980s. And it's a panel of questions and findings on clinical exam. And it's there to evaluate the clinical aspects of your Parkinson's symptoms. It includes a motor evaluation, which means how are you moving, and can characterize the extent the disease impacts you daily. And it provides an objective measure of function and dysfunction. And so again, it's very helpful in clinical trials because it's objective and not subjective, not just someone coming in to say, my tremor doesn't allow me to do things. It's a clinical way of testing how impactful your tremor is to you. And this scale is divided into 4 parts. So the non-motor aspects of experiences of daily living. Those can be things like sleep, speech, how is your mood, those kinds of things. The motor aspects, which we already talked about, the slowing, stiffness, tremor. And there's a motor subscale and motor complications. And the latter two, well, actually the first two and the fourth one are kind of questionnaire that the doctor will sit down with you and talk with you about these things. So it's really a questionnaire to go through with you on the how does Parkinson's affect your daily life. And then that third thing, the motor subscale, is a part of the physical examination. And as a provider, you can use any or all of the subscales to describe where you are at one point of the disease. And the higher the score, the more the level of disability. Personally, I use the motor subscale as a useful tool when people are thinking about maybe retiring in their job. It gives the reviewers who are looking at your disability paperwork a good objective measure of how difficult it is for you to move and do your job. And I find that's useful for folks. So here it is. It's quite it takes time to do the entire MDS UPDRS, probably 20-30 minutes. And again, most of the score or the scale is questionnaires and how does things affect your activities of daily living. And then there's a physical exam portion of it too. Typically, if you are going to see someone at the university level, they would likely have you meet with a clinical nurse to fill this out, maybe initial diagnosis, and then maybe annually thereafter. If you're in a clinical trial, this would be something that they're going to have you do every time, because this is a great way to determine, it's an objective measure of your abilities or disabilities related to your Parkinson's disease. So that's all I have for you today. I will open it up to Jeremy or Gary for any questions, or if you have any other comments. Thank you.
No problem. Thank you, Dr. Kokontis. I think that was great. It really hit all the high points we were looking for. So I appreciate you doing that. I would ask people if they have time right now in the Q&A to ask any questions that they may have of Dr. Kokontis' presentation. A couple things I'm going to ask that I just picked up as I was listening to your presentation. One of the things you mentioned earlier is a lot of people identified tremor with Parkinson's disease. But in your presentation, you said 30 to 40% of people with Parkinson's will never have tremor. Can you explain why that may be a little more difficult for people, since everybody assumes they should have tremor because it's Parkinson's disease?
Right. Again, it's a unique disease. It affects people differently. And that's, I think, if you have family that doesn't accompany you to the clinic visit, it'll be hard for them to maybe believe that that's so, because they do always attribute Parkinson's with a tremor, and they don't have a tremor, so they can't have Parkinson's. So, but that's not true. You can have Parkinson's disease and not have a tremor, or you can have a tremor and not have Parkinson's disease. That's why it's really important to come and get looked at. Don't worry that you have Parkinson's because you have a tremor, because there are various other tremor conditions that are not due to Parkinson's disease.
Perfect. Thank you for answering that. And it's one I hear a lot where people are like, yeah, my family gets down that I'm not shaken. Well, you probably never will.
Yeah.
You had mentioned in your presentation about caregivers coming to appointments, and somebody actually asked, should my caregiver be coming to an appointment with me? And maybe what are the benefits of having the care partner there?
Oh, I think I love it when family come. I love it. The more the merrier, I always say, because like I said, people don't notice things themselves. They may not be aware of it. It's their spouse or their daughter, son, whoever that notices what they're doing. And they're the ones that should be reporting to us so we can get the diagnosis. You know, history is all of it, pretty much all of the diagnosis. So it also helps us to, when we're telling things like the diagnosis, it also is nicer to have another pair of ears, because the more ears you have, the more people will remember. And then, you know, you don't have to explain to them when you go home, I have Parkinson's disease. You know, it's everyone's on board. You have the support. You can have the discussion. They may have questions that you never thought of. So I encourage people to bring their spouse or any of their family.
Yeah, I hear that a lot. Having the family member there is great because, like you said, they may see things I don't see, and you have
Right.
some good conversation, and it helps you a lot figuring out what's going on at home.
Right.
Versus, there was a doctor I knew one time. He said, "Yeah, you can always tell when they have an appointment because they remember to take their medications." And
Yeah.
like your partner, well, you should write them out on that, saying, "Yeah, they haven't been taking their meds, but today they really were good about it."
That's right.
From your standpoint as a physician, how important are support groups, and especially if you're a recently diagnosed or newly diagnosed individual, how important might those be?
Oh, I love them. I wish we could have them all day, every day for everyone, because I don't know, people are so, they just don't want to bother doctors. They think we're too busy. We're busy, but we're always available for questions. But those are the things some of the things that you may be embarrassed about talking about to the doctor, or you didn't remember. You can pick up a lot of details on questions that you may have at a support group. So you get a lot of information. You get a lot of support. There are other people that are out there that are just like you, that you know, if they hit and punch and scream in their sleep, yeah, there is someone else that's like that. That's not just me. See, you can tell your spouse. So I think it's very helpful. It's also nice to compare, not that, I know it's probably not I think it's helpful to know if what I'm doing is what I should be doing, or maybe I shouldn't be doing this, or my medication doesn't do this. Maybe I'm not on the right medicine. It kind of gives you a framework on which to build your practices on in terms of the patient, what I can be and should be doing and how I should be feeling.
Well, and I would say from a support group standpoint too, a lot of the groups we know that we coordinate with at WPA allow caregivers to come, and we find out that the care partners also have that outlet to share with people going for similar circumstances.
Right.
I'm sure you would agree to that as well.
Right.
Another question came in. You stated that people over 70 let me try that again. My reading is a little off. People who present with Parkinson's disease over the age of 70 progress faster with the disease. How much faster is the question, but can you maybe talk a little bit about maybe what do you mean by faster and what that progression looks like?
Sure. I guess to think about it, I'm thinking of some of the other maybe non-motor complications that you can see. So if you are 70 years old, actually, let me skip back. If you're 50 years old or 35 years old and you have Parkinson's disease, I wouldn't expect you to develop dementia at 50, but if you're 70 years old and you have Parkinson's disease, it's probably gonna, not unexpected that you would develop dementia at 85. So that's what I'm getting at, mainly those things. Not that the motor symptoms are going to become resistant to treatment differently, not that they do, but if usually you need to adjust the dopamine or the medications throughout anyone's course, no matter how fast or slow they progress. Everyone will need to have some changes in their medications. But if a younger person, I wouldn't expect to have postural instability or loss of balance quickly. That's just not something you'd see, as opposed to maybe if you're 75 and you have other orthopedic conditions, that loss of balance is sort of magnified because of your other issues. If you think about it too, when someone presents with their Parkinson's disease, about 65 to 70% of their dopaminergic neurons have already died off. So you're living with fewer neurons to try to pick up the slack. And as you age, those neurons are even less, because the normal process of aging is to, die off in your neurons. So it can be somewhat speedier in terms of progression from the initial symptom to the latter symptoms when you're older, just thinking about the processes.
I appreciate that. I think that was a great explanation and kind of hopefully answered Jan's question who asked that. One of the other questions I have that I get a ton, and I think you touched on it a little bit with the UPDRS and diagnosis. I hear from people, why do I have to do this every single time I do an appointment? And then I have to touch the fingers and I have to stamp my foot. Why am I doing that every time?
Yeah.
You explain a little bit what you're, from a clinician standpoint, why they're doing that and how that helps you in treating their Parkinson's disease.
Yeah, because it gives us an idea of how well you're medicated, how well you can function. So this thing, I take this for granted. I could do this till the cows come home and I don't have any decrement of movement, or I didn't get stuck. People who have Parkinson's, if their medications are wearing off, they're sticky, they can't move. Or maybe their medicines aren't wearing off, but they just never kicked in because we haven't really gotten them to the point where they can move better. So it's a good idea. And when personally, I usually ask them, when did you last take your medication? So when I examine them, I have a feel for where they're at in their dosing, and that maybe we need to change your medications. If you're at peak dose and you're still slow, and this is another measure of slowness. It takes forever to do that movement. And same with foot tap. We're looking at how quickly you can do a movement and does it get stuck? And so, if someone is doing this and tapping their foot and has no problems, it means that they're well medicated. Their symptoms should be well controlled, at least the motor symptoms anyway. And we do it every time just to see, do we need to make a change?
I think that's a great explanation. It's one, I've had people at support groups many, many times ask me, they're like, I do this every time, but I have no clue why I'm doing this.
Yeah.
And my sarcasm, I usually ask them, is the doctor playing the chicken dance for you? Because that's really what it's supposed to be.
Yeah, right.
And it takes them a minute to realize I'm not being totally serious. So I have two questions left for you. The first one is from a clinician standpoint. I'm recently diagnosed with Parkinson's disease. What is your outlook? What are you going to tell me as a patient that, hey, here's what you're going to look like, or here's your outlook, and what are the encouraging thoughts you have in relation to long-term Parkinson diagnosis?
Yeah, good question. I say it's up to you because, many years ago, I was practicing here for about 10 years, and I realized that there are two groups of people that I knew and took care of with Parkinson's. One group was people who are pretty sedentary, and they always had been in their whole lives, and their Parkinson's would become more, maybe progress faster, and their symptoms would be more difficult to overcome. They become more sedentary. Sedentariness begets more being sedentary. Then there are the exercisers who, before they had Parkinson's, exercised their whole life, and they continued to because it was a way of life. And their Parkinson's was, some barely progressing. And this was after 10 years. And so shortly after that, I kind of looked in the literature to see if there was any data on this. And there was, sure enough, just people were just like me noticing this very thing. And even studies began to be published. And now, of course, we know that exercise is huge in slowing progression of disease. And before, we didn't really know what type of exercise, and still that's being worked out. But we want you to get to be to the point where you're aerobic. It means you get sweaty and breathless. And if you can do that every day for several minutes, the guidelines are 150 minutes a week, which is 30 minutes a day, if you practice that 5 days a week. So it's not a lot to ask, and it really can give you a much slower course, a much better course with Parkinson's. And then, we're getting smarter. Our research studies are showing, even if I can cross over to the dementia, Alzheimer's literature, they're getting smarter in how to block amyloid and tau in the brain. Those are the proteins that are involved in not dopamine, but Alzheimer's cells when they want to die off. Similarly, alpha-synuclein seems to be a toxin to our cells. So we're starting to learn how to block those, and those may be total game changers. So I tell people this is the best time than ever to have Parkinson's, because you can slow it down by exercising and taking good care of yourself otherwise, until we have the cure, which hopefully will be within the next 5 to 15 years. And so I don't think the face of Parkinson's is much different than it used to be, even 20 years ago, for sure. Outlook.
Well, and I appreciate that. Without being coached, you really gave us a great bookend. That Friday, we're going to do a presentation on exercise from Patrick and Mary and show you some of the exercises you can do with Parkinson's disease and help slow things down. So I was handed one more question. Can we be over-medicated? And if we are, what does that feel like?
Mm-hmm. Yeah, you can be over-medicated. There's different over-medication symptoms. It can feel like you're dizzy or off balance or very sleepy. Some people develop unwanted motor symptoms. I call them the wiggles or dyskinesias. That means that when your medication reaches the peak concentration in your bloodstream, you get wiggly. And so that might be how someone looks, really wiggly when they're at top medication dose. So the way you would determine that would be to reduce your dose of medication, of course, with your doctor's advice and help. a lot of people end up on 2 or 3, maybe 4 different medications for their Parkinson's. So it's hard to know. I would imagine if I was a patient, which one is it? Which is the one that's making me over medicated? So I think that's a good question to ask your doctor and to help you find that out. Which is it that you can work with? Mhm.
Well, Dr. Kokontis, I want to thank you for doing this. I know you're retiring the end of May.
Yeah.
I'm going to say from a personal standpoint, I've worked with you for 8 years and have really appreciated working with you, as I know your patients probably have. And you've really contributed a lot to WPA, so we appreciate that a lot. So my last question for you is, retirement starts the end of May. What's the first thing we're doing?
Oh, I don't know. I haven't figured that out yet. I don't know. I think I might take a long nap. I'm hoping to sleep for a while.
Actually,
But then after
deserved,
that,
I'm
after
sure.
I wake up, I'm not sure.
Well, much
Thank you.
deserved.
Thank you. Thank you. I
No problem.
appreciate you.
Yeah, well, thank you so much. I'm going to step stage left. I'm going to bring Gary Garland up to say a few closing words. Thank you so much, Dr. Kokontis. Here's Gary.
Thank you.
Thanks, Jeremy, and I'll echo what Jeremy said. Thank you, Dr. Kokontis. It was, we here at WPA, and I know your patients will miss you. And that nap sounds like a great idea, not only for retirement, for all of us these days, but thank you for all your service to the Parkinson's community. So hopefully everyone here today will join us tomorrow. We're going to have Dr. Ryan Brennan from Prater in the Medical College of Wisconsin. He's going to be addressing treatment options for Parkinson's, including medications, medication delivery besides pills, and what deep brain stimulation is. So join us. And just a reminder, the link you used to join today for yourself is going to give you access to every day this week. So you use the same link. But if you have family or friends that you think will find this valuable, they need to sign up at our website, which again is wiparkinson.org. Really important, these programs are all being recorded and they'll be available next week sometime at our website. Finally, I want to thank again our sponsors for this webinar series, Medtronic, Amneal, Boston Scientific, and Kyowa Kirin. On Friday afternoon, you're going to receive a program evaluation as well as information from these sponsors. We're really grateful for their support in helping us make this happen. So thanks to all of you for joining us today. I hope to see you tomorrow and the rest of the week. Enjoy your day.